Okay, good morning again, and welcome everyone to Journal Club for September 2023. This Journal Club marks a transition of sorts. We have a new faculty lead for Journal Club, and that is a clinician scientist in our division, Dr. Jennifer Watt. And I know that Jennifer Watt is in transit at the moment to a conference. So I'm not sure if she's been able to sign on as yet. But a very warm welcome, and we look forward to Jennifer's leadership with the critical appraisal and leading our residents through that primary objective of Journal Club, and also take a moment to thank Shabir Alibi for countless years of service before Jen starts today. So thank you, Shabir. If you're online, I don't see you either, but thank you very much for your years of leadership with this aspect of our curriculum. So to start with the land acknowledgement, we recognize that many Indigenous nations have long-standing relationships with the land upon which the work of the University of Toronto's Department of Medicine is conducted. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississauga, the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. Land acknowledgements are only a starting point for larger conversations. More concrete acts of restitution and transformation are needed to address underlying inequities and blatant discrimination in the distribution of resources between Canada's First Peoples and settlers. And I recognize some of you have the orange color. Tomorrow is National Truth and Reconciliation Day in Canada, and a further day to reflect on this issue. So our first presenter this morning, Dr. Peter Hoang, PGY5 Geriatric Medicine, co-lead resident and also concurrently pursuing postgraduate training in clinical epidemiology. Peter is here to present on the MIND diet. Welcome, Peter. Please feel free to begin.
And the speaker volume is okay? Fantastic. Thanks, Dr. Kendall, for the introduction. And I'll be presenting today on the trial of the MIND diet for prevention of cognitive decline in older persons. And this study was published in the New England Journal of Medicine in July of 2023. I have no disclosures of interest. For our objectives, we'll summarize very briefly the current literature that was guiding this study, and then we'll review the methods and results before I provide my critical appraisal and bottom line. Over the last 20 years, there have been many observational studies looking for that one specific ingredient or supplement that can reduce cognitive decline. As shown in this slide, since 2000, there have been flavonoids, antioxidants, vegetables, omega-3 fatty acids, carotenoids, green leafy vegetables, vitamin D, and vitamin K, with all variable levels in their association with reduction in cognitive decline. Unfortunately, these studies fall into the same limitations of observational studies and self-reported measures. But if you had to make just one recipe and say, this is the one thing I want to eat for the rest of my life, I tried just that, and I used a recipe app that incorporates all of these things. And this is what I found. You can choose either baked ginger salmon with a sherry recipe, a mediocre 3 out of 5, or sesame crusted salmon harissa tagliatelle. That sounds pretty good. But perhaps it's not a single one thing, but a sum of its parts. What if I wanted a general diet? And that's exactly what the authors of the MIND study had in mind when they asked this question. In adults over the age of 65 with a BMI of at least 25 and a family history of dementia and initially suboptimal diet, does the MIND diet and its associated dietary counseling and social support group compared to caloric restriction targeting weight loss of 3 to 5% over 3 years, prevent cognitive decline as measured by a global score? For our inclusion that was described just previously, And in the exclusion, it's important to note that participants were excluded if they had any cerebrovascular or cardiovascular disease, psychiatric medications, or any mental health diagnoses, with some exceptions. Individuals had to complete a 3 to 4 week run-in period to assess their own adherence, and they had diet records measured at least 2 out of 7 days per week and had to consult a case manager. For those who were successful, they were randomized to either the intervention group, which was the MIND diet, and I'll discuss that very shortly, or a personalized diet plan that had compliance aids, group motivation strategies, and frequent monitoring. The control group was daily caloric restriction, targeting 250 calorie deficit and 3 to 5% weight loss, but otherwise non-pharmacologically supported, the same as the intervention group. To provide further clarity on the MIND diet itself, here are the foods to eat and the foods to avoid that are recommended by the authors. And as you can see, this is a hybrid of the Mediterranean and the DASH diet, and it recommends that you essentially have many green leafy vegetables and nuts, and you avoid red meats and things with high saturated fats. For our outcomes, it was a composite of the outcomes described in this slide, and these were measured at 6, 12, 24, and 36 months. The battery included executive functioning, perceptual speed, episodic memory, and semantic memory. And those specific tests are here, and the ones that I was able to publicly find, I left in an appendix in case the audience is interested. The secondary outcome was MRI, which they were able to non-randomly select 100 participants in each arm. And dietary adherence was measured by a self-reported diet, biochemical measures, in addition to weight assessment. For the statistical analysis, the authors calculated a sample of 300 based on a power of 90%, assuming attrition of 20%. They standardized the global cognition into a linear mixed effects models and used the variables in their equation as shown here, with the intervention arm, the site the participant was at, the average rate of change in their cognition, their baseline cognition, and used time when they showed up as an indicator. As we move into our results, there were 1,900 persons who were assessed for eligibility. And I want to note that a quarter of them already had an adequate diet as considered by the authors. From there, 300 were randomized in each arm. I'd like to give the audience a moment to consider the demographics of these participants. The average participant was 70, female, Caucasian, highly educated, experiencing obesity, and the only thing they had was hypertension. The only real baseline difference is very minor, and is the percentage of those who are carrying the ApoE4 gene. Over the course of the study, the average participant lost 3 kilograms. And using self-reported measures of adherence, as you can see here, participants were very adherent in the MIND diet to maintaining the Mediterranean diet. They also measured biochemical measures as described earlier, and that included many serum measures of folate, vitamin B12, tocopherols, carotenoids, fatty acid, in addition to urine tests. I left that as well as appendix material. The global cognition score was converted to a standard value, and each incremental follow-up is shown on the right, is the axis on the y-axis. And as shown in this slide, there is no difference in global cognition at any point in time compared to the control diet. And when separated by the different cognitive domains, this remained the same with no difference. The estimated mean changes are shown here with the MRI, which measured white matter hyperintensities, hippocampal volume, and gray and white matter. Between baseline and year 3, again, between both the intervention and control group, there were no differences. They were, however, only able to collect 100 out of the 150 that they wished in each arm. I now take selected components of the Cochrane risk of bias tool for randomized control trials with my critical appraisal, and I summarize that later into the actual risk of bias domains. Just for a reference, a Y means yes, and when it's green, it's low risk of bias. When it's red, it's higher for that specific question, and black is no information. Participants were randomized via computer sequence with minimal differences. All participants, as expected of a non-pharmacological intervention, were aware of the assignment that they had, in addition to those who were delivering the intervention. There were deviations that occurred, and that was because of COVID, and a small proportion had to be, were only able to have follow-up via telephone, but these were matched across both groups, and they additionally completed sensitivity analysis specifically of this group, and it, again, made no difference. Intention to treat principles were used in which the data was imputed for those who were, in which there were missing data. And there were multiple measures of adherence in both groups. And as we can see in the initial slides, this would be adherence, that individuals in the MIND study maintained adherence to the MIND diet. Dropout was under 10% in each group, a little bit more in the MIND intervention group, and that data was imputed. I didn't see specific sensitivity analyses on completers versus non-completers. But I understand that imputation would be the method of choice in when using mixed models. But I would welcome any feedback from the audience who has more experience than me in terms of this method. Outcome assessors were also blinded throughout the course of the study. And finally, this study had a pre-specified analysis plan and a pre-specified primary outcome. So I summarized all of that into the specific domains on the Cochrane risk of bias tool. And so for randomization, deviation from the intended intervention, missing outcome data, and measurement of the outcome, selection of reported result, these were all low. So this is a very high quality randomized controlled trial. So for the questions I asked the audience to consider, was this a sufficient duration? Is this perhaps a very highly selected group of patients? They all had to experience obesity, have a family history of dementia, and were highly educated. They had relatively low cardiovascular risk factors. Contrast that with the PREDIMED study that was published in 2015, where individuals with high cardiovascular risk factors did show reduction in their cognitive decline. And finally, this was in an active control arm. Again, the PREDIMED study was compared to a non-active. And so finally, I would like to ask the audience to consider the causal chain and ask what questions have we or have we not answered as a result of the study? Is it the diet and the sum of its parts that reduce inflammation, and that's why we reduce cognitive decline? Is it that diet affects some groups more than others? And for example, those in high cardiovascular risk factors are those who will have reduced cognitive decline. Or is it that healthy diet is actually something that's in between, and that it's healthy lifestyle, higher socioeconomic status, and those who are educated who happen to have a healthy diet, and that's why they have reduced cognitive decline. So for my bottom line, in highly educated older adults with obesity and a family history of dementia, the MIND diet is no different from a calorie-restrictive diet for global cognition and brain volume. And will you be mindful of what you eat? Thank you.
Thank you very much, Peter, for the beautiful presentation. Are there questions from the group? I know Dr. Watt has a question. And as I mentioned earlier, I think Dr. Watt is in transit. Go ahead, Jen, if you're able to unmute. If not, I will pose your question. So Jen's question reads, is this a pragmatic or explanatory trial? And why? And how does this design choice impact your assessment of the generalizability of this trial's findings to the patients that you see in clinic?
Yes, so my understanding of would be that this would be an explanatory trial. This is not pragmatic at all. These are participants who had a very comprehensive intervention. So all of them had to maintain this diet, had to have regular check-ins, had to have biochemical measures, and they even had to attend the support groups and cooking classes. That is not something that is practical for most people. And despite that, the outcome is negative in a very highly selected group. So for my participants, I would say I don't specifically, I still think a healthy diet has its role, and I'm never going to recommend the opposite, and I'm never going to recommend an unhealthy lifestyle. But the effect on cognitive decline, I guess, to me, leaves some questions.
Thank you. Gary, go ahead.
Thanks, Peter. Great presentation, as always, and I think you covered a lot of the important points. You know, one of the things that I guess stands out is when you look at the baseline characteristics, other than being overweight, you know, there's a very highly educated group with limited comorbidity. So, you know, you asked the question, was it long enough? You know, you wonder how difficult it would be for there to be a real signal here, given the group that's being studied. So yeah, they were very adherent to a diet, but you know, their risk factors were somewhat limited, and it may be really hard to show a difference. So I'll ask the usual question I ask when you guys present negative trials. Was this a definitive negative trial or an inconclusive negative trial? And what I mean by that is, if you look at the confidence intervals of the variables that were compared, do those confidence intervals include a difference that may have been meaningful, but it didn't reach statistical significance?
Yeah, thank you for the question. I personally feel that like these confidence intervals in the study were quite small in terms of the mean changes that occurred over time. And so in this selected group, as you describe, in a relatively short interval, I lean towards it being conclusive for a selected group. But I welcome if you feel otherwise.
I don't have the confidence intervals in front of me, but I have confidence in you, Peter. So.
Thank you. Barry, go ahead.
Just a brilliant presentation there, Peter. Thank you very much. You know, with the information coming in recently in the last few years that control of high blood pressure in earlier life is more important in preventing cognitive decline than controlling the blood pressure later in life. You know, I suspect that we're missing the whole point, which is lifelong dietary and exercise things, which was really highlighted very well for those of us who remember MacArthur study in successful aging. It's got to be a lifelong journey, I'm afraid.
Thank you, Barry. Any other comments or questions for Peter?
You know, to Barry's point, it's like comments made about osteoporosis. The problem with osteoporosis is, you know, you got to focus on sort of children and sort of young adults to have a good outcome later in life. And I guess Barry's pointing out the same thing is probably true about a lot of medical conditions. And it's hard to do that because those are not years that it's that easy to influence what people do.
And the idea of peak bone mass in young life being the predictor for osteoporosis was found by a geriatrician, Norman Exton Smith in England. So even childhood problems are amenable to geriatric knowledge.
Thank you very much. And Peter, I seem to recall that the PrediMed trial may have had some methodological or statistical analysis issues that later came to light that questioned the robustness of the validity of the study. But nonetheless, in aggregate, the Mediterranean diet is certainly one of the preferred diets. So thanks again for, I echo Barry and Gary's comments, a absolutely beautiful presentation, so well presented visually and articulated so well. Thank you, Peter. We will move on to our second presentation, and Guillaume echoes that as well. Great presentation, Peter. Please send us the recipe for that harissa salmon tagliatelle. So our second presenter this morning is Dr. Natasha Lane, who has previously earned a PhD in health services research before joining our program. And in addition to her current PGY4 geriatric medicine training status, she is a research fellow with ISIS as well. A warm welcome to Dr. Lane for her first presentation at our journal club.
Thank you so much. And do you all see the presenter view, or is it just me?
We see the slides alone and we can hear you well.
Wonderful. So thank you for the introduction. I don't have any conflicts to disclose. So today we're going through the Frail AF study. I will briefly review indications for VKA versus DOAC anticoagulants in AFib, and then go through what we know and what the guidelines tell us about how we should use these medications in people with AFib. We'll go through the trial itself and my critical appraisal, and then we'll answer the question, is this trial practice changing? So we'll start with a case. This is, I think, someone that we've all met in clinic. It's a 85-year-old lady that we're seeing for falls. She's from home alone. She's ADL independent. She gets help with meal prepping, groceries, and she has non-valvular paroxysmal AFib, CHADS2, EGFR of 64. She's mildly frail, and she's had 2 falls in the past 2 years. She's on warfarin. She's taken it since 2003, and she has a time in therapeutic range of 72%. Her son is a nurse and asks, should my mom still be taking warfarin? I've heard that apixaban might be safer and more effective. So I'm curious, you can think this to yourself, but who wants to switch her to a DOAC, and why? And I know Peter Hoang actually presented on this body of evidence a couple of journal clubs ago, and someone said, why is anyone on warfarin anymore? So I know some of you want to switch her, but we'll see what the evidence shows. So we all know the indications for VKA and atrial fibrillation, moderate severe mitral stenosis, because they were excluded from the DOAC RCTs, and mechanical heart valve from the Realign study, and of course if they have another indication to be on a VKA. In terms of the efficacy and safety of VKAs versus DOACs in non-valvular AFib, the original trials did have subsequent studies, like the original DOAC versus VKA studies did have subsequent RCT reanalyses of the 75 plus data, and it showed an advantage in terms of stroke prevention, but comparable bleeding risk between the 2 drug classes. Subsequent meta-analyses of DOAC versus VK and observational studies showed a significant advantage of apixaban and dabigatran in terms of reduced bleeding. But of note and relevant to this study, they didn't find a difference in bleeding between VKAs, Riva, or edoxaban. And then more recent meta-analyses that actually combine all of the trial and observational study data show decreased risk of thromboembolism and decreased bleeding with DOAC compared to VK, especially with the DOAC apixaban. And I know Peter has just recently summarized all this evidence in a lovely journal club 2 months ago, so I refer you to his slides as well. So the guidelines reflect this knowledge base. The Canadian CCS 2020 guidelines for AFib say that we recommend an oral anticoagulant be prescribed for most frail elderly patients with AF, so they don't think that older adults should be excluded from treatment because they're frail. And then when an OAC is prescribed, they say that we should preferentially prescribe a DOAC, except for in those cases that VK is preferentially indicated. They have a quote practical tip. They say consideration should be given to switching eligible patients from warfarin to a DOAC, particularly if they're unable to maintain a therapeutic INR. And this recommendation in the CCS guidelines is repeated in the European guidelines, where they're a bit more specific. They say if they have an INR less than 70, they recommend consideration of the switch without necessarily citing a lot of evidence. It's expert opinion. So this is a slide that shows on the left-hand side of the screen new DOAC prescriptions in people who are eligible for DOAC with AFib. And this is in all comers, all ages. And you can see that from 2010, when VKAs were being prescribed quite a bit, the incidence of VKA prescribing has gone down markedly. This is a global systematic review and meta-analysis of 21 studies. And conversely, you can see that since 2010, DOAC or NOAC prescribing and incident OAC prescribing has gone up markedly. And I think that this reflects what we've seen in practice as well. Importantly, though, that's incident prescribing. In terms of prevalent prescribing, of adults, not older adults, excluding frail people in this study, who should be on an oral anticoagulant per guidelines, 32% of them are actually still on a VKA here in 2018. And looking to a population that we know well, of eligible older adults entering long-term care, so people who are starting long-term care admission and should be on an OAC per guidelines, 15% of them were on a VKA in 2018. So these drugs are still around. We still see them in practice on people who might not have current indications for them. So the study said that they sought to answer two questions, but I think they really sought to answer one. They asked, does the superiority of DOACs over VKs in AF patients hold for frail patients? Well, the superiority that came out in the trials we just reviewed was for incident prescription, so I don't think that they're really looking at that. But they do ask, should frail patients with AF be on who are on VKA, should they be switched to DOAC, such as the case that we saw earlier? So the PICO for the Frail AF trial, and I apologize, my slides are not as pretty as Peter's, is the population had to be 75 years of age or older. They were recruited from thrombosis clinics in the Netherlands. They had to have a Groningen frailty index greater than or equal to 3, which we'll talk about briefly, and they had to be willing to switch, of course. The intervention was a switch from an IRNR guided VK treatment to a DOAC that providers could choose which one they wanted. This was a pragmatic trial. The control was continued with VK treatment, targeting 2 to 3 of an INR of 2 to 3 in these thrombosis clinics. And the outcome was major or clinically relevant non-major bleeding complications, whichever came first in the first year follow-up. And they had secondary outcomes, thromboembolic events, minor bleeding, hemorrhage and stroke, health-related quality of life, and cost effectiveness. The latter two they actually didn't report on in this study, but I'm sure we can look forward to seeing those later. They excluded people who had an eGFR less than 30, mechanical heart valves, severe mitral stenosis, and people who were too cognitively impaired to provide written consent. So like I said, this was a pragmatic, multi-center, open label RCT. They initially wanted to power it for a superiority trial. The patients were recruited from these thrombosis services in the Netherlands, which actually sound like they provide really nice care. And then they had follow-up at 1, 3, 6, 9, and 12 months by phone. And they said that they gathered additional information if the outcomes were detected by phone. It wasn't clear to me how they did that, like if there was data linkage or not. And then, of course, they did an intention to treat analysis of hazard of death, accounting for the competing risk of, the intention to treat with the outcome of the main bleeding outcome with death as a competing risk. So this is a frailty index. It's very small. I can't read it on my screen, so I don't know why I chose to present it this way, but it basically, you can score out of 15, and it includes items that are IADLs and ADLs in mobility, vision, hearing, nutrition, comorbidity, which is really polypharmacy, whether or not there are any cognitive concerns, psychosocial frailty, and then an overall self-rated health score. This has originally been validated to pick up frailty with a score of 4 or more. The study authors had a little bit of a hand-wavy explanation for why they chose 3, but they basically said people with AFib are more frail than this measure can pick up. And I will say that I looked around, and there actually has been a validation study in an older Chinese cohort showing that a score of 3 is actually the nicest balance of sensitivity and specificity, coming in with a sensitivity of 88% and a specificity of 79% for frailty. So although it differed from the original validation studies, this actually was validated later on. This is the flow chart. They started with about 2,600 people. Half of those people were cut before randomization, most for not being frail. They randomized about 660 people to each side, and then you can see the loss to follow-up was very minimal, only 3 in the VKA the VKA group and 5 in the DOAC switch group. And then there was a bit of crossover, which is to be expected in a pragmatic trial, but pretty good adherence to the interventions on both sides. So was the table 1 balance? So the mean age was 83 with a standard deviation of 5.1. The median frailty score was 4. So frail, regardless of which definition of frail you believe in for the GFI. I want to draw your attention to a couple of bars here, and they don't present standardized differences, which I would have found helpful because I thought some of these differences looked clinically significant to me. But the NOAC switch group was a little bit predisposed to bleeding, in my opinion. So you can see that they had higher risk of past bleeding, so 15% versus 15.9 versus 13.3%. They also had high risk of past thromboembolism, so 21% versus 17.7%. And they also had more hypertension, so 55% versus 50%, and slightly more of them were women. So the big takeaway from this trial was that there's actually more bleeding in the switch group, and let me walk you through this slide. So first of all, in the intervention group, the median number of days until people in the DOAC switch group actually switched to a DOAC was 52. So they were randomized, and then more than a month later, they actually switched to a DOAC, which again, this is a pragmatic trial. And the study authors found that most of the difference between the two groups actually kicked in at about 100 days, which we can see here. The hazards, they're overlapping until around 100 days. And then you can see the DOAC switch group really starts bleeding a lot more than the VKA control group. The primary outcome was the hazard of bleeds in the year, and their hazard was 1.69 with a confidence interval that does not include the null. And there was no significant difference in their hazard of clots. You can see that their confidence interval crosses null. This, and 90% of people died during a mean of 344 days of follow-up. In terms of what was driving this main effect, because it's a composite outcome between major and non-major bleeds, it was mostly the non-major bleeds that were driving the positive association. So the hazard was 1.77 with a confidence interval of 1.24 to 2.52. The hazard of major bleeds actually was not statistically significant. And they said that they stopped the trial due to the futility being reached, although I guess I was a bit confused by that statement because their plan was to follow for a year and they stopped at a year. So, but they did meet futility and that they did not want to see this big a hazard in the switch group. So this association between switching to DOAC actually held across most DOACs as well as age, sex, and EGFR substrata. And the only groups in which the confidence intervals crosses the null were people on switch to dabigatran, edoxaban, as well as women and people with a lower EGFR. I think it's really important here. It's small, but it's worth noting that 50% of people in the switch group were switched to rivaroxaban, which is interesting because it is a DOAC I would associate with being more at risk of bleeding. And 44% of people also had off-label dose reductions. So obviously this fact predisposes the switch group to bleeding more, and this fact predisposes them to bleeding less. So where were they bleeding from? So the biggest difference was in gastrointestinal bleeding. So you can see that this is the switch group, 9 versus 1 people, and the switch group had a major GI bleed, and 8 versus 3 people in the switch versus VKA group had a minor GI bleed. And then the switch group also had more skin bleeding, more urogenital bleeding, and really the VKA only had like very minor amount more of MSK bleeds. And then the groups had about equal risk of thrombotic events. So again, the hazard ratio was 1.26, but it crossed the null. It was pretty wide for thromboembolic events in intervention versus control arms. So again, Peter's was so much prettier, but this is my critical appraisal using the Cochrane risk of bias tool. So this is the summary. So I think there are some concerns in the randomization process, some with the assignment to intervention, low risk with adherence to intervention, low risk with missing data, some concerns for measurement, and low risk with the reported result. So that's 3 of 6 domains. So I have some concerns about the internal validity of these findings. And just going through them more specifically, of course, the allocation sequence was random. I think that there are some baseline differences between the intervention groups, suggestive that these groups were not perfectly alike. But again, if there are standardized differences somewhere that were not the supplementary appendix that show that these are statistically non-significant, then I could be convinced otherwise. And then, of course, the participants knew which group they were in, as did the people caring for them. And we can talk more about what these outcomes, the clinically non-major bleeding events were, but I think that they actually are subject to, it matters if participants know what group they're in. And then the missing data was very small, only 0.6% of people had missing outcome data. And like I said, people knowing that they've been switched from a medication that they trust and they've liked being on for more than a decade, I do think that could have affected the risk of some of the clinically non-major bleeding. And for the record, I didn't point it out in the table 1, but most of the people in the study had AFib for 12 to 13 years. So that's a long time to have AFib and be fiddling around to find the right drug that works for you. And then they had a protocol published a priori, and they reported on the outcomes that they said they would. So why all the bleeding? First of all, I think, we've talked about it. This design really selects for people that are doing well on their VKA. So if you've been on a VKA for 10 years and you're still on a VKA, like, you're probably not the person who bleeds on VKAs. So, and that's implicit in that is kind of the question this study needed to ask, but it does bias us against the DOACs. And then we talked about this before, but 50% of people were switched to rivaroxaban, which we know has a higher risk of GI bleeding than, say, apixaban. And we saw a ton of GI bleeding in the DOAC group. And they also, I thought this was really interesting, and they kind of glossed over it, but when we're switching from warfarin to a DOAC, we usually wait until the INR is 2, and then we are happy to start. Like, we stop VKA, wait till INR is 2, and then we start DOAC. And they found that was actually associated with a very high risk of bleeding after the first 100 subjects. So they changed it. They said, well, we'll wait till INR is 1.3, and then we'll start the DOAC. So they actually did that after 100 people in the intervention group had already been switched. But that is the highest risk period is actually switching. So if you take someone who's been stable on a medication and you put them through that high risk period, you will see bleeding probably. In terms of the generalizability, they excluded people with eGFR less than 30 and those incapable of informed consent, which certainly would be many of our patients, but they also had a really high quality of care in the control arm. They didn't go into it too much, but it sounds like these thrombosis services in the Netherlands are actually quite nice. Like, they have home INR monitoring for whoever needs it. They have a program in place for monitoring people on warfarin, which I don't think exists across all jurisdictions in Canada, for instance. I don't think it's generalizable having Riva as the first choice for the switch. I don't think that would be most of our practice patterns. And then in terms of the time and therapeutic range, so in their intervention arm, the time and therapeutic range for people was 65 to 74%. That is pretty reflective of an N of 500 study of people across Canadian provinces who had a time and therapeutic range of 74%. But I will note there are other subgroups, like in Brantford, where the time and therapeutic range is actually much lower than that. And these results don't necessarily generalize to that population. So in terms of the strengths, this is an RCT. They had good intervention adherence in both arms. They did use a validated frailty score to identify frail participants, which I think is important for us. And I think the study population is generalizable to patients we routinely see in outpatient settings. I don't think the choice of DOAC is necessarily, but there are generalizable aspects of this study. And the limitations are, we already talked about the bias in terms of the unblinded randomization and intervention assessment, the inherent selection bias built into the study. And I would have really liked to see stratification by time and therapeutic range on VKA. And it would have helped me more if they included people who had lower time and therapeutic range, because those are the people I would typically really be keen to switch. So in summary, they have a moderately frail cohort of about 1,000 older Dutch adults with AFib and an indication for oral anticoagulation. Those randomized from VKA to DOAC switch had a 69% increased hazard of clinically significant bleeds over a year and no difference in thrombotic events. The study was subject to the bias we've talked about, and they did not identify whether this unfavorable switch association persisted with patients who had a low time and therapeutic range. I'll return to this case. She has a good time and therapeutic range. She's been on warfarin for 20 years. She's not had any complications that we know of, and you can think about whether you still want to switch her. My bottom line, I say if it's not broke, don't fix it. And I do think that was kind of what the study looked at. They took a bunch of people who it wasn't broke, people who were doing okay on their VKA, and they tried to fix it, which I think we've all probably done at some point in our lives in this clinical scenario. I think if people are struggling to keep time in range on a VKA, I would consider swapping to a DOAC. Based on this trial and previous trials, I would not choose Riva. And I thought it was interesting, they're changing their INR switch cutoff. And I wondered if we should actually consider a different switch cutoff when we are switching people ourselves. That is the end of my talk. Thank you so much for your attention. I welcome questions.
Thank you very much, Natasha. Second fabulous presentation, and appreciate the provocative thoughts. Shabir has his hand up. Go ahead.
Yeah, thank you, Dov, and thanks, Natasha. I echo Dov's comments. This is a great presentation, very nice discussion, contextualization, bringing in information about Groningen frailty indicator. I just have a minor comment and a question, or actually, I guess 2 parts to the question. If you could go back to your conclusion for a moment.
Which, this conclusion?
The conclusion of the, not the bottom line, sorry, the slide before going back to the patient.
This one.
Yes. So it's always a good idea for all of us when we're looking at these studies and reporting them, whether we're writing them or reading them, to report both absolute differences as well as the hazards, because those hazards can look frightening. 69% increase, but it might be from 0.3% over to 0.45%. So can you remind us of what the actual increased absolute difference was? That was sort of the comment/question. But my more important question is, you raised an interesting concern about this INR business and when to switch over. And remind me, apologies if I missed it, did they do a sensitivity analysis excluding those individuals who were under the first protocol where the INR switch was a 2 versus 1.3 to see if it made a difference in terms of the increased hazard that they saw?
Yeah, so I'll answer your first question, comment, and then the second. So the absolute risk of outcome in the switch group was 15.3%, and in the continuation group it was 9.4%. So I think those are clinically relevant.
Yeah, agreed. 6% difference is huge.
Yes, and then in answer to your second question, no, they didn't present that sensitivity analysis, and I have to say, I'm not a trialist. But I was surprised at how little supplementary analysis they did provide. Like usually when I look at these trials in NEJM, like the supplement is huge and you're just like going through pages and pages. And this was actually a tidy little 8 pages of extra data. So I didn't know they didn't have that
Fair
sensitivity.
Point. Thank you.
Thanks, Shabir. Go ahead, Gary.
Natasha, great presentation. Certainly, I agree with your comment. They seem to stack the deck against the DOACs by taking a group that clearly tolerated being on vitamin K for extended periods of time, which generally with vitamin K, you see a majority of the bleeding fairly early on. So I agree with that comment. I may have missed it. So when you point to some of the differences at baseline, that do raise some concerns. The problem with randomization is it doesn't always work. If you have, huge numbers, it generally does, but the smaller the numbers, the less likely you get equal groups. So I guess the question, and one in particular, higher prior bleeding rates. Prior bleeding may be one of the stronger predictors of a likelihood of subsequent bleeding. Did they do analyses that adjusted for differences in the baseline characteristics? And did they confirm their results?
I don't think so. No, I think that they no. Now I'm doubting myself, and I'm just going to double check. But I do not, yeah. Blah blah blah. So they don't actually say They just say that they did Cox regression analysis, and they don't say whether or not they included covariates. So maybe it's not reported. And then they talk about stratification by the a priori variables like renal function and sex, but they don't talk, they even talk about like assessing the proportional hazard, but they don't actually say what variables went into that Cox model.
It's too bad.
I agree. Like I said, I usually expect to see so many more supplementary tables. Maybe the authors have them available on request.
Thank you. My question then, following this discussion, is given the possible failure of the randomization and the conclusion, might it be that there's really no difference?
Yes, yes, that is a possibility.
And then for ease of administration, and then my other question to the group would be, is there something to learn from the observational data of the millions of people that have been exposed? And I'm not sure if there is observational data on the transitional period.
I see multiple comments from the audience, so I'm interested to hear what they have to say, and then I'm happy to comment.
Go ahead, Barry.
I can't comment on that specific question. It's just that of the patients I see, most have requested a change to a DOAC because they don't want to keep getting their blood tested. And, you know, this is a different kind of pragmatic trial because the kind of care they were getting is not what most of our patients get. So, you know, I've had in the last few years, I've had exactly one patient who wanted to stay on vitamin K or wanted to stay on warfarin. So I think that whatever we decide as brilliant scientists is not swaying anybody in the population. They want to go on DOACs.
Go ahead, Shabir.
I think you have to be very cautious, just going back to your question or comment about whether baseline differences in randomization may have explained the outcome. I mean, first of all, obviously we know that the larger the sample size, the more likely randomization will succeed. There may be minor differences between groups, and some people advocate that you adjust for those if they're important in the analysis, which I think Gary was alluding to, and Natasha pointed out that they do not appear to have. But even if we ignore that and assume that, okay, there's a 5% difference, for example, in the switchers for higher risk of bleeding, that would be assumed then that they would have 100% greater likelihood of having the outcome, because the outcome difference was 6% on an absolute scale. That would be incredibly difficult to justify. And so the likelihood that the increased risk of bleeding is due primarily or predominantly to imbalances in randomization would be exceedingly low.
Even when the numbers are so small, I understand the percentages, but the numbers are very low.
Yes, but on an absolute scale, like if you think about the difference in groups and you try to plot this out, there are factors that we haven't accounted for. There are factors that are not known, and even though the absolute difference in the groups in terms of risk of bleeding, even if it's 20%, 30%, 40% greater among those who are imbalanced, to lead to an absolute difference of 6% would be very difficult. I have to sit and plot out the math for you, but just sitting and doing it in my head, it would be quite unlikely. And others can chime in, but it's unfortunate that there's a bit of imbalance, but it's not a gross imbalance in my mind. It certainly is not enough to likely explain the outcome.
Thank you. That helps. Thank you. I'll also add to support Natasha your concern with rivaroxaban. The AGS 2023 Beers criteria gives a strong recommendation to avoid rivaroxaban in this population.
Yeah, I thought it was an interesting, I mean, there's lots of data showing that Riva is not ideal because of the bleeding, but I have seen it used in Geri because it's once a day dosing. And if people need supervised meds, then it's sometimes easier to get that at home once a day than twice a day. But this will add more pause for me the next time I think about doing that for the once a day dosing versus the bleeding risk. And I think even with the we talked about with table 1, even with these differences at baseline, I would still use the data from this study as part of informed consent if people did want to switch from a VKA to a DOAC.
Great, thank you very much. Any other questions or comments from the
I will open them.
audience? There's another comment in the chat box. Congratulations to both our presenters on excellent presentations. We're a few minutes from the top of the hour. By way of announcement, please do look out for the Journal Club evaluation link, which has not arrived in your inbox yet, but will be coming. Also, I think that perhaps Jennifer Watt and Shabir Alibi were not on at the very beginning. But again, I wanted to thank Shabir for his leadership on the Journal Club portion of our curriculum over the last decade or more, guiding the residents through the article selection, presentation, and critical appraisal. And a warm welcome to Jen on an exciting future ahead with some adjustments to the Journal Club in terms of formats and other ideas that are in the pipeline. So thank you very much, Shabir, again, and thank you, Jen, or welcome, Jen. And thank you to all the residents who I think there's unanimous consensus that present such fabulous presentations and contribute to such rich discussion. And no better example than the 2 presentations today. Thank you, Peter. Thank you, Natasha. And thank you, everyone, for joining.